Good morning and good afternoon. My name is Emily Eberly, and I will be your technical host today. Here is a big thank you to Teleflex, who was our sponsor for today's program. And this webinar is being presented to you today in association with the Infusion Nurses Society. And on behalf of Teleflex, I want to thank you for joining us for our Vessel Health webinar series. And now I'd like to introduce you to your moderator, Mary Alexander, who is the Chief Executive Officer for the Infusion Nurses Society. Mary, here's a very warm welcome to you. Are you ready to get started?
I sure am, Emily. Thank you so much. I also want to welcome everybody to today's webinar and remind you that following our presentation, we welcome your questions. The title of today's webinar is Enhancing Accountable Care Through Improved CLABSI Outcomes. Speaking on this important and timely topic is Roxanne Peruka, Director of Magnet and Nursing Excellence, Vascular Access Team at the University of Louisville Hospital. Ms. Peruka has over 30 years' experience in the specialty practice of infusion nursing. She is a past president of the Infusion Nurses Society and a past chair of the Infusion Nurses Certification Corporation. Ms. Peruka has published several peer-reviewed journal articles and has contributed chapters on infusion therapy-related topics. Ms. Peruka has presented many local and national infusion nursing educational presentations. Ms. Peruka disclosed no conflict of interest in the development of this presentation, and no off-label use of products is discussed in this webinar. This presentation is sponsored and funded by Teleflex, Inc. This education activity is approved for 1 contact hour. Provider approved by California Board of Nursing, provider number 14477, and the Florida Board of Nursing, CE provider number 5017032. At the end of this webinar, you can obtain your continuing education credits by logging on to www.saxtesting.com/VH. Complete the post-test and evaluation form, and upon successful completion, you will be able to print your certificate of completion. Now, it's my distinct pleasure to introduce today's speaker, Roxanne Peruka.
Thank you, Mary, for your kind introduction, and also to the Infusion Nurses Society for their support. And a special thanks to Teleflex for sponsoring today's webinar, and also to each of you for joining us today. And I am delighted to be your presenter. So today we will discuss what is the intent of the Affordable Care Act. What's its purpose? Why was it designed? We will also discuss what are the outcome metrics that have been adopted by CMS, as well as describing what is the impact as a clinical outcome measure, and why CLABSI as an outcome metric is so very important. And last but not least, what is the clinician's role as far as promoting accountability and improving outcomes? What is our professional responsibility, and how can we add value to our organization? So healthcare reform, whether we like it or not, was really designed to address our current healthcare challenges that we see every day in the clinical setting. So whether we like it or not, this is what the Affordable Care Act was designed to address. We have an aging population. We have increased burden of chronic diseases. Many patients present with 4 and 5 chronic illnesses. We have rising patient acuity and complexity of care, which increase costs and growth at a national level. We have many consumers that lacked a basic access to health care, and especially wellness and prevention. And affordability was a challenge. We have a very expensive healthcare system, and despite all that, we still have, even though we have one of the most costly healthcare systems in the world, we have significant gaps in quality. So healthcare reform is here. almost every magazine, every journal, every article, you can find something about healthcare reform. It's truly front page news. So the Affordable Care Act was passed by the Senate and the House in 2010. It was signed March of 2010 into federal law, so it's a statute. And so we're 5 years into accountable care. And how much do we really know about it as a healthcare professional and also as a healthcare consumer? So there's lots of speculation, a lot of unanswered questions, a lot of what I call in the gray, because no one really knows. It's really projected on estimates and speculations, and many times. But one of the changes we really are seeing is the influx of patients into the healthcare system. Approximately there's 20 million people who previously were uninsured that now have coverage. But what's the long-term effect for that? No one truly knows at this point in time. Ever since the Affordable Care Act has been signed into law, there has been multiple challenges. It was upheld once in June of 2012 in the Supreme Court, and currently we're awaiting a Supreme Court decision in midsummer of 2015, and that's related to the tax subsidies and the legality in the 34 states that expanded Medicare. So the intent, the overall purpose of the Accountable Care Act was to identify and implement programs that reduce waste and healthcare cost. Also to provide greater access to primary care, and a great focus is on wellness and prevention. And also to provide an efficient and effective acute care. So there are 3 mandatory payment programs in the Accountable Care Program. And we will be talking in detail about each of these pay-for-performance programs. But a very important piece of the Accountable Care Act is also the triple aim. And many CFOs and CEOs will tell you that it's actually all about the goals of the triple aim. And the triple aim is a framework that was developed by the Institutes for Healthcare Improvement, and it was to design an approach to optimize the performance of the healthcare system. Some things that we do know by passage of the Accountable Care Act is that healthcare is shifting out of the acute care setting into the community, into alternate care sites. So for that reason, hospitals are anticipating a decreased revenue stream, decreased profits. The margins are tightening. So there's also, and you probably see it in your settings, there's a lot of system integration. There's a lot of merger. There's a lot of acquisitions. We actually are into a system now here at U of L. And so it's that we can be bigger, but the other thing is that we can be a one-stop shop that actually meets all the healthcare needs for the consumer. So overall, this is a very turbulent time in healthcare, and it's actually been compared to 1965 when Medicare rolled out. So very turbulent time. So the first pay-for-performance program in the Affordable Care Act is value-based purchasing. And this is a definition for value-based purchasing. It's really a performance model that rewards or punishes hospitals based on performance against process and outcome measures. And I always think the title's really a misnomer, because if you ask most clinicians, what do you think value-based purchasing is, they're probably going to tell you, well, it's about group purchase contracts for the purchasing of supplies and equipment. But the real purpose of value-based purchasing is to create a material link between reimbursement and clinical quality and patient experience. It's really a financial incentive for hospitals to improve quality instead of quantity, the volume of care that we provide. So this is a dramatic shift. So value-based purchasing is based on the hospital performance. And it basically works that the government, CMS, withholds a portion of a hospital's reimbursement. So we report on our outcomes, on specific outcome metrics that we'll be discussing, but they assess how a hospital's performing compared to other hospitals on a national average. Oftentimes this is your competitor hospital and maybe the hospital that's down the street. And this comparison, this benchmark, is actually what determines your reimbursement. So you'll see on the side of the slide for 2014 that if your hospital is above average and you have high performance, you receive a bonus. You receive your full reimbursement and a bonus. However, if you are a low-performing hospital, your performance is below average, you do not receive full reimbursement, and you actually are penalized as a result of that. There is a penalty. So they keep your money. And if you happen to be an average performing hospital, you earn you're neutral. You're not fully reimbursed, but you don't receive a penalty. You're just neutral. So you break even. So the important thing to remember about value-based purchasing, that if you are a high-performing hospital, you are fully reimbursed and you also receive a bonus. You're rewarded for that. But the opportunity, and this is where it links with CLABSI, if you are a low-performing hospital, you're basically giving your money away to your competitors. So this is the value-based purchasing timeline. There's several things that's important to point out on this slide. That value-based purchasing assesses a hospital's performance in 5 categories that are listed on the table. And so it's things like clinical processes, your core measures. That's actually, if you notice on that timeline from 2013 to 17, that's actually decreasing the core metrics. Patient experience is your HCAHPS scores, your patient satisfaction results, and currently, and we'll talk about the 2017 reimbursement, but that's 25% of the reimbursement. Outcome metrics is the mortality index, and then you'll notice in the safety index there's 2, and this is the AHRQ composite, and then you notice CAUTI is listed as one of the 5 indicators in that second safety component. And you will notice in 2017 that CAUTI was just added as an outcome metric to that safety component. And then efficiency is related to things like the flu immunization, fibrinolytic agency, an AMI if it's received within 30 minutes upon arrival to the hospital. So that's the efficiency component. But the other thing that is really important to know about this is right now, 2015 is the performance period. So the data that we are reporting to CMS will be paid out in 2017. So there's always about a 2-year lag time. So that's why it's very important that, we are a high-performing organization and that we have excellent CLABSI outcomes. So the second pay for performance program in the Affordable Care Act is hospital readmissions. And it's a reduction program. The purpose is to encourage hospitals to reduce readmissions within 30 days. And it's only on the conditions that are listed. So if the condition isn't on that list, like AMI, heart failure, pneumonia, COPD, the total hip arthroplasty, you're not penalized if a patient is readmitted. So it's only on those conditions that are listed where the penalty, and it's a punitive structure as far as the readmission reduction program, but the penalty can be up to 3%. And unlike value-based purchasing, there's no monetary reward if you're a high-performing organization. So in other words, there's no carrot, it's only a stick. So the third pay for performance program that's identified in the Affordable Care Act is the reduction of healthcare associated infections. And this is some of the data that we're probably all familiar with, but it's reported that 1 in 25 hospitals has at least one healthcare associated infection. And so this is some of the opportunities that we have for improvement. This is the measurement for hospital-acquired conditions, and there's two domains in this program. And so it's the AHRQ, which is the Agency for Healthcare Research and Quality. They list central venous catheter bloodstream related infection as one of the measures, as well as the CDC measures. So both of these domains are included in the healthcare acquired condition program. So what's important about this? So why are they both? And you'll notice that CLABSI is the only indicator that's in both categories. And so the reason for that is CLABSI is truly classified as a never event. It should never happen. And this program, as we discussed with the readmission program, there's no bonus in there. It's a penalty-only program. So if you're not a high-performing program, you receive no bonus. You're only penalized for low performance. So what we see occurring is that the current revenue system in the acute care setting is shifting from a pay-for-procedure, so volume-based, to pay-for-performance, to a quality-based. And historically, we've always been volume-based. It's like the more procedures, the more patients we get through, the higher our reimbursement. But we are shifting, we're being forced to shift to quality. So we have to produce value. And so from the advisory board, they actually say in 2015 that 42% of hospitals are reporting that at least 10% of their revenue is currently tied to value. So 42% of hospitals and at least 10% of their revenue is tied to value. However, within the next 2 years, hospitals are projecting that at least half of their revenue will be tied to value-based performance. So 2 years, at least half of the revenue will be tied. So we are shifting. The sands are shifting as we speak. Now, I was at a department head meeting last week, and our CFO used the analogy that currently the revenue system for a hospital it's like being in canoes. You're on the river, you have 2 canoes, you have 1 foot in a volume-based pay-for-procedure system, but the other foot, the other canoe, you have a foot that is pay-for-performance, and it's in value and high performance. So it's a very uncertain time as as any CFO or CEO will tell you. So we have a transformation going on in healthcare. In the current state, we are seeing tightening margins. The bottom line is shrinking. We have very complex patients, high acuity rates. We are getting patients, we call it patient throughput, getting patients through the system quicker. We're sending them out into the community settings, the alternative care sites, and we have an increasing accountability for outcomes of being a high performer, and along with that, greater transparency as far as public reporting. So some of the impact of CLABSI, we know that the most vulnerable patients, those patients that are in the intensive care unit and the NICU, have the highest risk for the occurrence of a CLABSI. And the CLABSI is a major contributor for mortality and morbidity. And increased length of stay with the occurrence of a CLABSI. It's estimated that the hospitalization the length of stay is increased from 12 to 17 days. And with the added estimate cost of anywhere between $24,000 to $51,000. So, and also that doesn't even include the prolonged and the frequent unnecessary exposure to antibiotics. So through the years, we have had a reduction in CLABSI. If you go back to 01 and compared to 09, we've actually had a 58% reduction in the occurrence of CLABSIs in the ICU. We've had significant improvement. Some of it's been related to the technology advances as far as prevention and some of the techniques and strategies, evidence-based practice that we use. But we still have a lot more work to do to get to zero. So one thing that you do know about the CLABSI is publicly reported in Hospital Compare, and this is a CMS website and Medicare.gov. And the intent for public reporting is to help improve a hospital's quality of care. And this is always from a consumer perspective. So it's quality data, patient experience data. You can go in and compare up to 3 hospitals for public reporting. And as of last week, the system just changed to a 5-star rating program. And so that is new. Currently, the advisory board is reporting that only the small specialty hospitals that are performing elective surgeries, such as spines and knees and hearts, are actually the only healthcare systems that are currently receiving a 5-star rating. So also outcome metrics are reported to the Joint Commission, and we will be discussing in detail the National Patient Safety Goals. And the focus of the Joint Commission is really implementation of evidence-based practices that prevent the occurrence of CLABSI. And of course, the National Patient Safety Goals do include peripheral IVs as well as CVC, central lines. So this is some of the kind of a short list of some of the most frequent references in regards to evidence-based resources. You see the CDC, which oversees the NHSN database, which we'll be talking about. AHRQ is very much about research and utilizing evidence-based practice. The Infusion Nurses Society, of course, it's the standards of practice. And of course, the Joint Commission, that's an excellent, if you're looking for lots of information about CLABSI, they publish, you can go to that website and retrieve their toolkit. It's very detailed, very, very extensive. So I will say on this, the CDC guidelines and the infusion nursing standards of practice are currently under revision. So watch out for those updates. So the bundles strategy has really been one of the primary tools, resources that we have utilized to improve patient safety and our performance for CLABSI. And the AAHRQ has listed checklist and bundles as one of the top 10 strategies to encourage patient safety and to improve CLABSI outcomes. So this on the screen, this slide is actually the insertion bundle that I'm sure many of you are very familiar with. However, there's also a maintenance bundle and some of the critical steps that are necessary for high performance and achieving high CLABSI outcomes. So the maintenance bundle, you'll notice, very important. I think this is one of the opportunities we have oftentimes in the acute care setting is the assessment of the line, a necessity, and that's a daily assessment. If the line's not needed, get it out. And also compliance is one of the major challenges, hand hygiene before and after each patient contact, ensuring injection sites are covered by caps, valve connectors, scrubbing the hub, tubing changing recommendations, and of course the dressing changes. So that's some of the maintenance bundle recommendations. So I think standardization and consistency, that every provider does this each and every time. And I think that's some of the challenges that we face within our healthcare system. I do want to talk about measurement because measurement is very important in reporting CLABSI data, and two of the major databases are the NSHN, which is the National Healthcare Safety Network, and this is the CDC website, but also the IndianQI, which is the National Database for Nursing Quality Indicators. And I will say they were recently, IndianQI was recently acquired by Press Ganey, and this is a very robust database. The last I heard, there was about 3,500 hospitals reporting into IndianQI. And what's important about these databases is the national benchmarking. And so when you compare data, it's very important that you compare apples and apples, that you compare like comparison groups. And each one of these databases allow you to stratify your data, so that you compare an academic medical center to an academic medical center. You compare a community hospital to a community hospital. So you can compare bed size. But what's really important to note about that is we have very different patient populations. So when you compare data, you have to use like comparison groups. The other, and most of you are familiar with, we have the measurement. They're listed for CLABSI. And what's important about this, I think the challenge is, and it can be burdensome, is the counting of the number of central line days. And this is the CDC definition. It's very important that if a patient has more than one central line in place, you count one central line day. You know, you can go to our ICUs and you will see patients that will have 4 and 5 central lines. However, that counts as one central line day. So the other thing that is included in the CDC recommendation is that you can count catheter device days manually or electronically. However, it's very important that every day you retrieve the data, you count at the same time each and every day. It doesn't matter if you choose midnight, 4 a.m., whatever works best for your organization. But what is recommended is that you validate. If you're counting device days electronically through electronic medical record, that you validate your count against the manual count, and that you compare for 3 consecutive months both methods. So the difference between methods should be plus or minus 5% of each other. And what's important is that you identify a cause. and you resolve the issue if you have any variants. And then you conduct a comparison for another 3 consecutive months. And so you repeat, you go back, do it all over again, you compare. And until you eliminate that variation of plus or 5% of each other, you continue this cycle until you get the issue resolved. And so that's very important, because predominantly the majority of us are using electronic medical records, and we're retrieving our device days. And I will tell you, organizationally, we just did this comparison audit, and we found out that our electronic days were higher than what our manual days were. So we are currently going back and looking at what the cause is and to see if we can resolve this issue. So that's very important, that you have accurate denominator days when you count device days. So this is CLABSI site-specific criteria, and this again, for a central line, that it doesn't matter where the catheter is inserted, it's where it terminates, that is one of the greater vessels in or near the heart. And in the neonate, the pediatric world, that's the umbilical artery or the vein. Another update in the NSHN, starting in this year, 2015, there was a definition change in the infection window. Previously, this had always been 48 hours, and now it's 3 days. That it's 3 calendar days before admission and 3 days after the line is taken out is the infection window. So that is the time that you count a CLABSI. And this is the definition for a CLABSI. It's very important from a standardization that we all use the same definition of how we define a CLABSI. And it's a primary bloodstream infection. And it can be laboratory confirmed or the mucosal barrier, and we'll talk about these in just a second. But a primary bloodstream infection is not secondary to another source of infection in another body site. So it is the primary source. So very important. And so some of the most common CLABSI organisms that you will see are listed, but it's very important to remember that the patient's skin flora is the primary cause of CLABSI. So those organisms are listed, and if you would like the complete list of the common organisms for CLABSI, you can go to the website that is listed, and you'll get the complete list. So to confirm a CLABSI, and that the catheter is indeed the primary source of infection, this is the criteria, and we do report this into NHSN and also into Indian QI when we're entering data. If it was which type of laboratory confirmed bloodstream infection it was, or if it was an MBI. So this is the criteria that must be met, one or these are both, that it's a recognized pathogen cultured from one or more blood cultures, and the organism cultured from the blood is not related to infection at another site. And laboratory confirmed bloodstream infection 2, and the criteria is the patient's signs and symptoms enter into this, but the fever, 36 degrees Celsius or greater, chills and fever, and again, the same as before, that the laboratory results are not related to infection at another site, and organisms are cultured from 2 or more blood cultures drawn on separate occasions. And in the neonate world, laboratory confirmed infection number 3 is patients less than or equal to 1 year of age and has at least one of the following signs and symptoms, which is fever greater or equal to 38 degrees Celsius, hypothermia, apnea, bradycardia, and the same again, and positive lab results not related to another site infection, and that the blood cultures are from 2 or more blood cultures on separate occasions. A new definition for CLABSI, and this was, we started counting this in January of 2015, and this is mucosal barrier injury, MBIs is what we call them. And again, this is confirmed by this is a laboratory confirmed bloodstream infection, and the patient meets one of the following criteria. We see these in our bone marrow transplant patients, the allogeneic bone marrow transplant patients. You'll see they have graft versus host. Another criteria is that they have greater than 1 liter of diarrhea in a 24-hour time period, or it can be in the neutropenic patients. So this is a new classification. This does not affect, this is counted separately in our data reporting. These do not count as CLABSIs. So this has been very helpful in the bone marrow patient population, because we always felt like our data wasn't accurate when these were included in our overall CLABSI rate. So we know that especially we have very high-risk patients, the ICU, the NICU patients, and severely immunocompromised patients. They really present a major challenge to us. So it's really important that you drill down your outcomes. You really ask those who, what, when, where, why questions. How, who inserted the line, what kind of a line, where was it inserted, the location, and you really do that drill down. So some of the questions you need to ask: how are we doing the basics? Are we performing hand hygiene? Is every healthcare provider, cleansing their hands before and after? Patency as far as the catheter lumens, site maintenance, dressing changes. And so you analyze your data, and then you may give, especially in this high-risk patient population, you may give consideration to what I call the big guns, with catheters coated with antiseptics or antibiotics, thin film as far as chlorhexidine impregnated dressings, or antimicrobial injection caps, or utilizing chlorhexidine for patient bathing. And I will tell you, in our very high-risk patients, we do all of these in our healthcare setting. So as far as the National Patient Safety Goals, this is from the Joint Commission. So this is really the framework of what we do as healthcare providers. And the goal of the National Patient Safety Goals is to improve patient safety, and the goals focus on problems in the healthcare system as far as safety and how can we resolve them. So there is a whole section, it's section 7 in the National Patient Safety Goals that specifically deal with CLABSI. And so we're going to hit the highlights here. The focus begins with education, and it's really of all healthcare providers that insert and manage central lines. It's upon hire, and it's annually. But anyone that has involvement in these procedures, they need education. And whether that's during nursing orientation, unit-based education, during annual hospital competencies, but healthcare providers need the latest evidence, and they need education continually. So the next patient safety goal also says education needs to be provided to patients and families about CLABSI prevention, and this should occur prior to insertion of the central line. And the Joint Commission also stipulates that policies and procedures, they must meet the regulatory requirements, but they also need to align with the evidence-based standards from CDC and professional organization, the standards of care. And then it recommends that periodic surveillance audits, assessments of CLABSI are conducted on a regular basis, and that is hospital-wide. That is just not in targeted areas or with specific patient populations. So overall, it's very important transparency within your organization. And I will say that CLABSI is one of our organizational goals. It's actually evaluated in our pay for performance as far as leaders and nurses within this organization. Some of the things we've already talked about as far as checklist and standardization, but it really involves every healthcare provider that is providing care to this patient. And so that may be standardization as far as a supply card or kits for insertion and for maintenance of the line. The sterile barrier precautions have been around for quite some time, but it's really noting what is the latest evidence as far as some scientific literature and staying comprised of that so that you're informed. So, in summary, value-based infusion care is here to stay. With the healthcare transformation and the reimbursement to value, it's not going away. So it's truly our professional responsibility and the value we bring to our organization to promote patient safety by preventing the occurrence of CLABSI. So some of the things we need to do as healthcare providers is become certified. You know, expand your knowledge and your practice. Be a lifelong learner because the evidence changes continually. It's like, so we need to know what the latest evidence is. And I also encourage you to talk to your leaders within your organization. Talk with your CNO and see what you can do to promote patient safety and improve CLABSI outcomes. So CLABSI prevention begins at the time of insertion, and just remember that infusion care is transitioning beyond the hospital. It is moving faster and shifting to other patient care settings. And the target is zero CLABSI. So I thank you for your attention today, and I look forward to your questions.
Thank you, Roxanne, for a most informative presentation. And we have plenty of questions that we will be getting to in a moment. This education activity is approved for 1 contact hour. You can obtain your CE credit by logging on to www.saxtesting.com/VH. Please complete the post-test and evaluation form, and upon successful completion, you will be able to print your certificate of completion. This webinar has been recorded and will be available on demand at www.vesselhealth.org. CNEs are available for the archived version. And now we have some questions from our audience. And there's lots of questions, and we'll try to get to as many as we can in the time that we have. Several people have asked about disinfection caps. Roxanne, have people found that disinfection caps have made a difference in the CLABSI rates?
Well, that's a very good question. So thank you for asking that question. I think what you have to look at in evaluation is you have to, it goes back to looking at your CLABSI outcomes. You have to look at your outcomes, where are your infections occurring, what patient population groups, and I will tell you it's mixed as far as the evidence. We do use antimicrobial caps in our bone marrow transplant patients, which I consider our highest. We actually have about 8 ICUs here, but our bone marrow transplant patient probably has the most severely immunocompromised patients as a group. So we do use antimicrobial injection caps in our bone marrow transplant patients, and I will tell you it made very little difference as far as our overall CLABSI outcomes. And so that's truly the only nursing unit that we use the antimicrobial injection caps in our hospital. But again, I think you have to look at your own organization. You have to do the drill down with your own data, your own metrics, and analyze if it's worth the cost or not at this point in time until we get greater evidence. So thank you.
Great. Shauna wants to know, are large and small hospitals compared against each other in reporting CLABSIs?
No. If you use a national database like NHSN, the National Healthcare Safety Network database, or in Indian QI, you actually, when you look at your data, you can go on and select the comparison group that you want to benchmark your data to. So no, there is no comparison between a large teaching hospital and between a community hospital.
Okay. Nisha wants to know, does the Joint Commission also cover chronic hemodialysis catheters?
To my knowledge, thank you, Nisha, that is a good question. To my knowledge, the answer to that is no. I always go for dialysis catheter, only in regards, I guess I will answer that, only in regards to central lines overall, but not specifically to dialysis catheters. And I would look at the National Network with Kidney Disease, the KDOQI guidelines, for specific information related to dialysis catheters and the management of dialysis catheters.
Okay, thank you. This is kind of a long question from Jeanette. With the new NHSN definition, it's almost impossible to completely prevent CLABSIs since you may have another type of infection, but if a blood culture is not part of the definition and a culture of that site is not done with matching of the cultures, it cannot be attributed to that other infection. If the patient has a central line, it has to be called a CLABSI. How would you propose to prevent those?
Okay, I'm not sure I understand the intent of the question, so I may have to respond to that one offline to get that. I'm not sure I have an answer for that.
Okay.
I'm sorry.
That's okay. We've got others. Lucinda wants to know, are blood cultures drawn from a central line accurate? Our facility requires 2 peripheral cultures be drawn and not drawn from the central line.
And Lucinda, you are absolutely right. We highly recommend, because the colonization of bacteria on catheters, which can be in the inner lumen, we avoid drawing blood cultures from central lines as much as possible. Occasionally, when you are unable to obtain blood, sometimes you have to do that, but it's very important when you send those blood cultures to the lab that you identify that was a culture that was drawn from a central line, but we truly try to avoid that because you're absolutely correct.
Sandra asks, what is the difference between the CDC CLABSI metric and the AHRQ CVC related infection metric?
I don't know of any, I'm going to be honest with you, Sandra, I don't know of a difference between, because the AHRQ, that was in the healthcare, it really doesn't identify all the characteristics or the attributes of infection. It's truly the CDC is really the primary organization for the identification of a CLABSI, and AHRQ is more, it's more research, evidence-based, as far as making recommendations to prevent CLABSI. So they don't actually, they would go back and use the CDC definition. So thanks for asking that question.
Mm-hmm. Lynn wants to know, do you have any idea when the CDC and INS will be updating any of their guidelines or standards?
Well, what I have heard, and I have heard that the CDC is updating various components, and I do know of their guidelines, and that the Infusion Nursing Society is in the process of updating, and it will probably be in 2016 before both are available for publication.
Yes, I can confirm that the INS standards, yes, I can. The INS standards of practice will be out in January, February of 2016.
Awesome.
So you can all stay tuned for that.
Super.
Janice would like to know, do you have a list of reasons to remove a central line?
No, but I could certainly write one out, Janice. Really. So, no, I don't have a formal list of reasons to remove a central line. Obviously, it's some of the obvious. If it's not being utilized, I really, for the administration, I mean, sometimes central lines just stay in for convenience of the healthcare professional, and those lines, they really need to be taken out. It's, especially in this day and age, it's too high a risk. It really is. But, no, I don't have a formal list, but I could certainly write one up fairly quickly. Mm-hmm. Yeah. Thank you.
A couple of folks have asked, what's the recommended way to manually check the number of central lines? Is it more effective to use a vascular access team or have individual nurses reporting them?
Well, that's an excellent question, and I have to tell you, it's when you're a large organization, I mean, it's burdensome to figure out what is the most accurate way to count device days. It's challenging. What we currently do, because we're in the middle of the audit, so we are looking at our electronic device days that are counted by the our medical record system, and what we're doing manually is every nursing unit, so we have about 17 nursing units that are literally, and they're doing this during report, but they actually have a tally sheet. So we're looking at our central line days, and we're also looking at our CLABSI days. And so during report, it's a part of bedside shift report, but they tally. So that's really the only way we figure it was most accurate for doing that manual count for device days. And so then what they do is they fax that report to our infection control department, and then they analyze the data and do that comparison between the manual count and the electronic count. And that was the best way that we could figure out if it was the least burdensome. So, and I have to tell you, in my experience, is most vascular access teams simply do not have the personnel to go around and do that on a daily basis. So thank you for that question.
Mm-hmm. Gracie is asking, is there data for ambulatory clinics or the outpatient population as it's relating to CLABSIs?
At this point in time, and you remember I'm an acute care person, we do have outpatient clinics and stuff. There is not outcome CLABSI data for these areas. It's always on people's horizons to count and to have CLABSI data, but at this point in time, as far as counting CLABSI data, it's just not available in these national benchmarks.
Mm-hmm. Roxanne, Gail is wondering, is it a realistic expectation to have zero CLABSIs with CDC definitions?
It's a challenge. I think it is realistic. but we have a lot of work to get there. And it's very challenging, I will say that, as far as our patient populations, the complexity of care, and it's very challenging, but I think it is realistic. I think it's an achievable goal. We just have a lot of work to do.
Mm-hmm.
Yes.
I would agree. Debbie is asking, how does the government ensure that the data received by the facilities is accurate and not falsified?
Well, that's a good question. I don't, I have to tell you from my perspective, I don't know of any way that they do validate that the data is that an organization is accurately reporting their data. I'm not aware of any mechanism. I will say from a Joint Commission perspective, they actually come on site and they look at, you provide your CLABSI reports to them. So I really don't know from a CDC perspective if they ever validate their data.
Mm-hmm.
So I know I report data into Indian QI, and there's actually no formal process about validation of your outcome metrics.
Mm-hmm. Lisa is asking, do you perform daily CHG baths in your bone marrow transplant patients?
Thank you, Lisa, for that question. That's a very good question. Yes, we do. So our bone marrow transplant patients, they are bathed. We have the chlorhexidine wipes, and so that is used in patient bathing on a daily basis, yes.
Okay, let's see. From David, for maximal sterile barrier precautions, is the patient covered head to toe for PICC insertions?
Yes. Short answer is yes. Yes, it's very important to reduce the risk of contamination. So yes, for maximal barrier protection, it's just what it says, that the patient is covered from head to toe.
Mm-hmm. And in the as we're reaching our time limit, this is going to be our last question, Roxanne.
Okay.
It's from Jennifer, and if you have a positive blood culture but a negative catheter tip culture, does that affect it being, is it considered an actual CLABSI?
No, because the tip would have to be positive also. I will tell you, and it's because of the cost cutting and stuff, we rarely anymore culture catheter tips. Previously, we almost always, in previous year, almost always cultured the calf tip to confirm a catheter-related infection. And now the reality is very, very few catheter tips are cultured. So predominantly to identify a CLABSI, we're really dependent on our blood culture information. Mm-hmm. So thank you for that question.
Mm-hmm. Well, Roxanne, thank you so much for a great presentation and for answering all the questions. I'm sorry we weren't able to get to all the questions from all our participants, but I do want to thank everybody for joining us. And at this time, I'm going to turn things back over to Emily.
Well, thank you, Roxanne and Mary. The material that you've covered with us today is vitally important to the enhancement of accountable care through improved CLABSI outcomes. And I want to thank you for everything that you shared. And finally, last but not least, I would like to thank each and every one of you, our guests in the audience today, for your time and your very thoughtful attention. Thank you, everyone. Take care and bye for now. Thank you, Roxanne and Mary.
Thank you.
Thank you.